chest pain, damn it, do an EKG. And what if the EKG is negative? Okay, so it's not that. So there's no evidence, right? There's no evidence at the time that it's a heart-related issue. What other things could that chest pain mean? Is there a problem with getting air in or out? Is there a problem with tumors, edema, swelling? You have to start looking a little bit more specifically. But unfortunately, in medicine and healthcare, a patient comes in with chest pain 9 times, I'd say 99 times out of 100, they get an EKG. So we tend to link and associate very specific signs and symptoms with the tests that they're going to get. The tests, as you know, in patient assessment, simply confirm our suspicions. They don't tell us what the diagnosis is. They confirm or deny our suspicions. So if you do an EKG and there's no abnormal pattern, then we've just denied that it's chest or heart related as far as blockage of a coronary artery, right? So we've denied that sign or symptom, depending on how the patient expressed. Now, chest pain would always be a symptom, right? Based on how we've described signs and symptoms. Symptoms are always subjective. We can't measure a person's chest pain. So maybe that's more of a constitutional symptom. So my point is, though, is that 99 times out of 100 we do an EKG, and we wouldn't confirm that it's a heart-related issue. It's coming from somewhere else. That chest pain is coming from somewhere else. So then we look at, is it on deep inspiration? Is it pleurisy? Is it the inability to get the air out? Is it a tumor? Is there a smoking history that would cause us to think that there might be bronchogenic carcinomas? So we have all of these possible complications from a constitutional sign or a symptom. It's how the practitioner goes about investigating that sign or symptom, and how patient assessment, or your knowledge at least of these particular signs and symptoms, that help to lead us more directly to whatever that diagnosis is. So chest pain is a particularly difficult one, but the routine is, especially if you're a male between 55 and 75, 100% of those guys get an EKG because it's obviously their heart, right? But it takes away, we could ask very specific questions. Do you have a smoking history? Could it be bronchogenic carcinoma? Are there blockages? Are there other explanations to having chest pain? Is there pleuritic type chest pain? Are there exposures to certain kind of allergens that would bring on an asthmatic type of an attack? So we often make judgments, and my point in this particular section of patient assessment is that in constitutional signs and symptoms, we often make judgments based upon age, sometimes race, sometimes socioeconomic background, sometimes gender. We make assumptions about disease pathologies, and I'm not saying that that's necessarily wrong. I'm just saying we need to be very particular and careful about what we associate and how that might lead us to a particular specific diagnosis. It doesn't always take us to the place we want to be. So we have to be open at least to other possibilities, that a 65-year-old with chest pain isn't always a heart attack. You see what I mean? It could be from a long-standing smoking history that now the patient has bronchogenic carcinoma. But my point is, with including this in patient assessment, is that we have to be astute enough to ask the questions. We have to ask the right questions to get upon appropriate diagnosis. And that's what patient assessment's all about, is learning where assessment comes from. Is it from a textbook? Maybe some background information is from a textbook on patient assessment. After you start practicing, is it going to be in professional journals? I hope so. You're going to ask your own questions, and you're going to see your own patients, and you're going to have to make judgments and decisions based upon signs and symptoms elaborated by your patients. They might describe hemoptysis. Now, hemoptysis is chest-related. It doesn't necessarily point to the heart. It's probably from several pathologies. We could consider tuberculosis. We could consider pneumonia, especially community-acquired pneumonia, or what's the specific one? Community-acquired or pneumococcal pneumonia. It's community-acquired. But we would sometimes see hemoptysis or red or rust-colored secretions with pneumonia. So in this section, what I'm trying to do is I'm trying to marry signs and symptoms, very specific things. Red frothy secretions, some of you put that with your response. Red frothy secretions is an indicator of pulmonary edema. And pulmonary edema means that there's blood in the secretions. It's not hemoptysis per se, but it's relative to heart kinds of difficulties and the fact that there's blood in the alveoli, maybe from low proteins. We could look at the blood, the constituency of the blood. We could look at the contractile force of the heart could cause pulmonary edema. So things associated with the heart and the chest especially, chest pain, associating pneumonias versus protein problems in the circulating blood. What about cough as a constitutional symptom? A lot of you in your exams put that cough was the most important sign or symptom with the least diagnostic value. And that's true. We don't often make a diagnosis based on a cough alone, although the one I can think of is croup. Croup is distinguished by its cough. So a cough by itself, we have to ask other questions. And I think part of what patient assessment is knowing what questions to ask. If the patient has a particular cough, we know that that's chest-oriented. But then it takes a lot of information to try to distinguish where that cough is from. Is it because of an irritation of the upper airway, or is it from secretions in the lower airway? Is it caused by a chronic cough that a patient coughs every day? In that particular case, it's interesting as a constitutional symptom that patients won't recognize that that's a constitutional symptom because it's something they do every day, or they'll even deny the fact that they have a smoking history. They won't recognize it as being anything unusual because it's something that's normal and constant and daily for them. So the practitioner has to really be conscientious of the possible diagnosis and the implication, in this case, of a cough. Cough is not particularly, it doesn't tell us a great deal, but if we can ask follow-up questions about a cough, it might tell us a little bit more. And that's where we have to get to. We have to know and be perceptive enough to follow up with what kind of a cough, if it hurts in your chest in a particular area, if there's blood associated with that cough, if the air has trouble getting in or out, if it's associated with particular allergens, like when they're around hay, or whether they're around particular animals or horses or cats or anything specifically that they might have allergies to, and then we start working on a diagnosis towards asthma. So in patient assessment, we're often given the task of very broad, non-specific kinds of complaints. Our role in manifestations of pulmonary disease is to marry the signs and symptoms with the possible diagnosis, but then again being open enough to kind of come up to a conclusion about what the common problem is. Make sense? So I think next week we've got the study guide. Can someone look ahead at the questions just so I kind of give you a heads up? So this is in manifestations of pulmonary disease. And I just want to make sure we're on target.
This week.
This week?
Yeah, so next week is terms.
Terms, okay. What were the study guide questions this week? So is that today?
Yeah.
Discuss
about
the importance of the
constitutional
clinical
sciences
evaluation of
symptoms.
breathlessness.
Breathlessness, there's an
Yeah,
interesting one.
breathlessness.
How do you investigate breathlessness? You know, I feel kind of short of breath.
There's the scale, the Modified Medical Research Council
Yeah.
questionnaire.
So that's a very non-specific kind of a complaint, right?
Mhm.
So if someone sees a practitioner and that's their complaint, I'm breathless, or I don't feel like I can catch my breath. Well, what kinds of follow-up questions do you guys have for
Just
that?
recently happened? or
Yeah,
is
recent.
Is it ongoing?
Good.
You just exert yourself?
Good
or-
distinction, yeah.
Yeah.
Is it associated with activity? You know, how is that dyspnea
Yeah.
associated with or without activity? Is it present when you're sitting quietly? Or is it when you get up to go to the restroom, or if you go down and pick up the mail?
Mhm.
So breathlessness is a really interesting constitutional, in this case that would be a symptom. We really can't distinguish breathlessness. We can't measure it.
Mhm.
You know, sometimes, like a pain scale, we kind of ask for a 1 to 10 rating, and then that kind of gives us some objective information. But by itself, a cough and pain, breathlessness, dyspnea, those are all very subjective. What are the other ones in that one?
Is that extra?
There's-
Oh,
explain the importance of
extrapulmonary
extrapulmonary
signs.
signs.
What am I talking about with extrapulmonary signs?
Like your renal, your cardiac.
Okay,
Is it like
so how are you going to evaluate that?
things that happen because of pulmonary issues?
Sure. So what kinds of things would you notice outside of the chest and rib cage?
Edema.
Yes.
Ankles.
Specifically, if your ankles are swollen.
Yeah.
If you have pedal edema, that's a chest-related problem. But here it is, an extrapulmonary sign,
Uh-huh.
right? Extrapulmonary means outside of the chest or outside of the lungs. So if your legs are swollen or your ankles are swollen, you have 3+ pitting edema, automatically we start looking at the heart.
Uh-huh.
So that's an extrapulmonary sign that lets us look more specifically at problems with contractility of the heart. What else? Another one, I think some of you mentioned it,
Digital
clubbing of the
clubbing,
digits.
yeah.
So clubbing is an extrapulmonary sign because you can see that the digits are clubbed. What that means is that they have venous to arterial to venous anastomosis. So what's happened is the blood vessels bypass the fingertips and the toes in an attempt to conserve oxygen. So clubbing is compensatory. It's compensating to conserve oxygen, and so you get these weird-looking clubbed digits in your fingers and your toes because your body's trying to save or conserve oxygen. Sometimes you'll see circumoral cyanosis. That's outside of the body or outside of the chest, but it focuses on edema and bluish discoloration of the lips. But then you start looking at, okay, why are you not diffusing oxygen as efficiently? So cyanosis by itself, or circumoral cyanosis. So that's what I mean by extrapulmonary signs or symptoms is things outside of the chest that cause you to focus on the chest. Okay, anything else on that one?
Gas exchange in a chronically diseased patient and the relationship of oxygen and carbon dioxide in the stimulation of ventilation.
So we often do a blood gas, and when we talk about oxygenation and ventilation, patients that have chronic hypoxemia, like COPD, COPD is always just the classic example of any pulmonary disease or respiratory therapist that knows about lung disorders. So CO2s are chronically high. Respiratory failure is often the case with COPD patients. I've seen COPD patients with CO2s of 110. And they're perfectly fine, they're functioning, they're up and walking around with CO2s of 110. But they've compensated for that. In fact, this gets back to today. A patient with 110 CO2, how would they compensate?
Dumping loads. Or no, holding on to lots of bicarb.
They retain bicarbonate in the urine. So the kidneys are retaining as much bicarbonate as they can. And when we do a blood gas, it's a real common blood gas. In fact, when I see this in a patient, 7.34 CO2 of 110 millimeters of mercury. What should it be?
40.
Yeah, it should be 40. I've seen them 110. PO2, 50 millimeters of mercury. What should that be at sea level?
70.
You need 100 at sea level,
Oh, sea
70
level,
here.
sorry.
Yeah.
Sorry. Here.
CO2, PO2, bicarb. This should be
24.
22 to 26. And 21, it's 43. So I see a blood gas like this and I say, how long have you been smoking? So that's a sign. That's a sign that this patient has overly compensated.
I got some thick blood.
So if a patient was at 110 CO2 and it just happened, they would not be okay. at all.
Correct.
Okay.
They would be out on their ass, basically.
And their bicarb probably wouldn't be.
Their bicarb would be 24. Yeah, that would be an acute respiratory failure. And their pH would be 7.1. So you can see, and what I'm trying to do with this chapter in A&P is to draw your attention to the power that you have of looking at acid-base balance and making an instant diagnosis. You can look at those ABGs and be able to tell. This is what I usually see in chronically compensated COPD.
So would that be something that would just gradually happen?
Over time,
Because-
yeah. This takes years to get there. But we see patients like that all the time, Caitlin. All the time, every day in clinical, and I'm surprised. I'll bet you some of you have seen them. You know, and they have very particular symptoms. They'll sleep upright. They'll fix their elbows. They have prominent sternocleidomastoids because they're using their accessory muscles to breathe this way, then up and out this way. And you can just tell. You can just tell. And you often don't even need a blood gas to tell you that. So if what patient assessment's doing is it's trying to help to draw your attention to all of the physical characteristics, all the signs and symptoms that help us to marry diagnosis from certain kinds of pathologies. So this assessment, the ABG then becomes an assessment. An EKG is an assessment. PFT is an assessment, and we'll look at those three things specifically next semester. We'll do ABGs, PFTs, and EKGs specifically to look at heart and lung disorders as an assessment of the degree of pathology going on in a patient's chest. So I see a blood gas like that, I automatically ask, well, how many years did you smoke? Or if I see a blood gas like this, with a CO2 of 6 and a bicarb of 13. So this one would be a respiratory acidosis. Here's how we marry patient assessment with anatomy and physiology and acid-base balance. So this would be a
Kidney
respiratory, because the CO2 is so high, respiratory acidosis.
Kidney failure.
This one, what on earth is going on here? CO2, PO2 is 100. So there's an assessment of a blood gas, an acid-base balance, but I'm going to marry it to pathology.
It's a kidney failure.
Yeah, this one is metabolic
Renal failure.
acidosis.
Compensated in there.
And it's compensated. Yes, that's what I was trying to do earlier. I wanted to bring in the difference between partial compensation and full compensation. We'll do that more fully next semester. But basically, this is a metabolic acidosis because the bicarb is so high, so low. So the bicarb is causing the acidosis, the low bicarb. The CO2, let's see. I put an arrow to the wrong one. So the bicarb is what's causing that. That's a metabolic acidosis. Here, it's the respiratory, the CO2 component causing the acidosis. Here, it's the bicarb causing the acidosis, and I'm hyperventilating to blow off CO2. So this is a metabolic acidosis partially compensated by blowing off CO2.
And it's partially compensated because the pH is still low.
Very good. It's partially compensated, because what would the pH be if I wasn't compensating at all?
Way low.
Holy shnikey. Yeah.
In the 6s.
You'd be in the 6s for sure, and you'd probably be dead.
Yeah.
The fact of the matter is you'd be dead with that one.
Yeah.
So the fact that we can hyperventilate to minimize pH changes, that's saying something for Henderson-Hesselbach. We acutely compensate for that metabolic acidosis. So metabolic problems compensated by respiratory compensation. In this case, respiratory problems compensated by metabolic compensation. And those all become ways for us to assess. So the acid base we talked about first thing this morning is now being used as an assessment tool to help us to understand respiratory failure and diabetic ketoacidosis as a disease pathology. Because those are very specific gases that we'll see as an assessment to marry the assessment with a pathology. So complete compensation would mean that the pH would be back to within normal, 735 to 745. That's completely compensated.
Which probably couldn't even happen in this case.
We couldn't, it couldn't. This one, over a year's time, we could get enough bicarbonate to cover that CO2. But we'd have to have 20 parts of this for every 1 part of CO2. So I don't know if I dare even try to do that just to make a point. I'll leave it up to you, Caitlin. Shall we try to compensate that that respiratory acidosis with enough bicarbonate to cover that?
No, I think it's good.
Something we need to know?
I get the idea.
As long as you understand the idea,
Yeah.
the bicarb would have to be 50 or 55 or so
Which would
for
take a
a
long time.
110. I just want to try to see 55. So what I'm doing is I'm thinking about it in terms of the hydrogen ion concentration.
Mm-hmm.
55 bicarbonate and 110 times 0.0301, that equals H2CO3. What's 110 times 0.0301? You got a calculator there somewhere?
3.1.
110 times 0.0.
You got me curious, Caitlin.
Is it 3.3?
3.3, yeah.
3.3. 55 divided by 3.3.
16.7.
16. So now we're at 16.1, 16 to 1. So my bicarb would have to be probably around 60 in order to balance that, to get it back to 7.1.
Wow.
7 point. Have you ever seen a bicarb of 60? A challenge in your clinical rotations to find a patient that has a bicarb even in the 30s.
Yeah,
Your
that's
COPD.
insane.
So this would be double that. So you could do it. Your kidneys could do it. If you were so diseased that your CO2 was 110, your kidneys would have to compensate by retaining bicarb up to about 60.
How long would that
Compensate for
take? Forever?
It'd take a hell of a long time.
Yeah.
Not
But see,
worth it.
but if you understand that concept, then you understand how the body's trying to compensate for, in this case, respiratory failure. Or you understand how or why the CO2 is 6 when your bicarb is 13. You're trying to compensate for that metabolic acidosis, and you're doing it through hyperventilation. So that's how we arch back around and make sense of patient assessment in an anatomy and physiology kind of a way, if we understand the underlying pathology. Okay, well, I better stop there. So